Yes, sir.
Yeah, good evening, friends. Welcome to the Indian Arthroscopy Society Basic Arthroscopy Learning Techniques webinar today evening. Dr. Maheshwari did our inaugural webinar on the basic concepts of arthroscopy, indications of arthroscopy, and initial techniques of arthroscopy. And this was a pilot project in which we invited delegates to join in live on Zoom platform and ask questions directly to Dr. Maheshwari. We were quite happy with the response, and I think we got very positive response from delegates, because for the very first time they were able to interact rather than typing their questions on a chat box. Dr. Maheshwari was kind enough to agree to our second lecture series today, in which he's going to talk about problems of doing basic arthroscopy, which beginners usually face, and the complications. And to coordinate and run through, we have excellent panel today. We have Dr. Ranajit from Odisha joining in, and Dr. Aslam from Vishakhapatnam. So I must welcome Dr. Maheshwari and thank him for his kindness to part with the knowledge, and also ask Ranjit and Aslam to actively coordinate as a panelist regarding this webinar. So over to you, sir, Dr. Maheshwari.
Right. So I'll share my screen.
Yeah. So anybody who wants to ask a question can stop in between, and that's the style of Dr. Maheshwari, that he does not mind people stopping in between. You can just raise the hand in the Zoom platform so that we can have a look at it, and then so there is a bit of discipline and we can ask questions one by one. Sir.
I'm okay. Somebody even from the panelists or the moderators just stopping me in between, and let us make it more interactive. So
Perfect.
In the last webinar, we did touch about what problems you can come across while doing arthroscopy. In the question answer, people did ask some questions which were probably okay at that time, but this time it is going to be in the shape of a proper talk where we'll try to cover what problems one faces when you start doing arthroscopy actually. The previous talk was what are the basic things, what are the indications, what happens and all that. But now that you are decided to do arthroscopy, you've gone into the operation theater, everything is in order, and you're trying to do arthroscopy, what happens now? You know all the theory, but now it is practical. What problems can come and how to go around that. And I will request my panelists and also the moderators to fill in the blank wherever I'm missing something, or maybe if they have something to add. So let me proceed with this, and my next slide. So first message is arthroscopy is a very different game from what we have done from our internship onwards. In surgery, we have learned open surgery, all of us. And once you learn skill of open surgery, every new surgery is no different to you. It's just another chapter. So if you can do A surgery, you can do B, C, whatever, because you know how to cut, how to sew, how to do what. But arthroscopy is a different cup of tea. It is very equipment dependent. It's like driving an aeroplane. And when you're used to driving a car is different. But flying an aeroplane is absolutely different thing. You have to know the nitty gritty of everything. So all this new equipment, you should know what are they, what do they mean, what are the different switches and all these, and what are these complicated wires going everywhere. And if you are not aware of this, nobody in the OT is aware of all these things. And once you're scrubbed up and you are in gloves and gown and something doesn't work, and you tell somebody, he shows you a blank face, and then you're stuck because you're scrubbed yourself. Sometimes I had to go at the back, tell him, okay, do this, do that, which is not okay. So you must know your equipment very well, because it is a very equipment dependent surgery. A lot of time the equipment itself fools you. There should be one person who should know everything inside out in the OT with you. So, and you are that one person. Nobody knows it as good unless you train somebody over a period of time. So in the beginning, you know everything, which button, what happens, so that you can, without de-scrubbing, tell the person what to do about it. So that's very important to know, because these are the lot of hiccups in this surgery because of equipment. Now, arthroscopy, like any other surgery, has a learning curve, but it has a very funny learning curve. You learn arthroscopy a little bit, you think you know it, and then another procedure comes, and then you again start learning again. Then you think you know it, then you add another procedure. So ACL, and then PCL, and then root repair. You keep learning. So it is a ever-ending learning curve which goes, and you were in a confidence, of course, you were here, and then you reach there, but it is a lifelong learning. Every time I take out the hamstring graft, even today, after having done more than 1,000 semi-tendinosus harvest, there is something that clicks to my mind every now and then, and I modify my technique. It's a learning curve all the time. And whatever may be written in the book, you have to devise your own ways of how it works. That's why so many people have different ways of taking out the hamstring, because it is what fits in your mind and what appeals you. That's the learning. So it's a learning curve issue, and you have to keep learning over a period of time. Now, 5 steps to a successful arthroscopy. Once you're in the OT, you want to do a good job. This is what is required. One, that you should be able to see, obviously. Normally, in open surgery, you see with your eyes, there's nothing. But then here, because you are seeing through an equipment, through a keyhole, it is a different game. You should be able to see what's happening. If you can see, you should be able to orient. Sometimes you can see inside, but you don't know what's happening. Where is the meniscus? Where is the ACL? Whether it is normal or not. So orientation, because you're not seeing directly through your eyes, you are seeing through the camera. And as you twist and turn the camera, turn the cable, things may look very different. So you have to orient yourself. And the third is to be able to reach the lesion, because next step after you have seen something, you want to reach that lesion with the help of a probe, with the help of your instruments, and then comes the next learning technique, what we call triangulation. So you should be able to reach the lesion. Once you are able to reach the lesion, for example, you can take the probe anywhere. The next learning is to differentiate normal from abnormal. What may look abnormal on your first vision, and once you probe, it may look normal, and vice versa. So you have to start feeling and differentiate. And this point number 4, of course, takes a lot of time. Very often, even today, I'm confused whether this ACL is torn or it is lax or it is partially torn. So it takes a little while, but I think over a period of time, you understand and make up your own mind. Now, finally, of course, every arthroscopy today is to do corrective surgery. And as I told in the last talk, that it is all pre-op planning. Your roadmap to going to the OT is in your mind before you start your surgery, which means what am I likely to find based on your clinical examination, based on your MRI, what am I going to find inside, and what am I going to do? So my plan A, plan B, plan C. Even when you know everything on MRI 100%, it very often gives you a surprise, and you should be able to be prepared to do every surgery ABC. Otherwise, you come out of the OT frustrated, and you're thinking, when I see the patient next time in the clinic, he might just say, "Doctor, my problem is not solved." So if you don't have a detailed planning of what all could be possible inside and how are you going to fix it, you will be facing very uncomfortable times with your patient. So these are the 5 important steps if you want to be successful in doing arthroscopy. Not only doing arthroscopy, but producing a result. So number 1. So these are problems I've noticed when my fellows join and I tell them, okay, put the scope in. And there's a problem even in inserting the scope. Now you should be able to insert the scope effortlessly. It is a very important statement, effortlessly, because the inhibition of coming out and going in should be not there in your mind. Very often we can't change scope from A portal to B portal to C portal because we have this inhibition. If I come out once, I'll struggle to go in again. And that happens in real life. And this is one such video when he's trying to put, but he doesn't know where the portal has gone away. And now he's hitting because the direction has changed and he's hitting the tip to the capsule, cannot go in. And these small things can frustrate you a little bit. And arthroscopy is a branch where you have to keep your cool. And if you set your system such a way that everything flows smoothly, more often than not, you'll be successful. If you struggle at any place, your performance goes down by 100% to 95%. So you should be clear as exactly what you're going to do so that it is a smooth sailing all through. Even something as simple as entering the joint as I showed you. And so this is what I do. To make it easy, So this is what I teach my residents, that once you make a small cut in the skin, introduce a straight artery forceps. So introduce a straight artery forceps in the direction exactly where your cannula is going to go, and just it perforates the capsule. And once it perforates the capsule, open up the artery forceps like this and bring it out. In a way, you have dilated the capsule inside or made the entry inside bigger. Now, every time you go in, it's a big entry inside. Outside, it may be a small entry, but inside it is a big entry. And you will see every time you go in, it's a matter of just going in wherever. It can move anywhere. And I start my arthroscopy from medial side. It just goes there, I can feel it. So entry and repeat entry becomes very easy because I dilate my capsule inside or entry into the capsule inside with the help of the artery forceps. This is to make my insertion and reinsertion easy. Now, there are problems in making portals, and even the first portal, and you should be mentally prepared for it. If you're not prepared, again, you make a wrong portal and you struggle, and it makes your performance from 100 to 95 to 90 very quickly. You tend to lose cool. Obese patient, obviously there's no marking, there's so much fat. You should take your time, maybe use a marking pen and exactly find out where. You can take a needle and find out where is the portal, and then make a portal where it is a soft spot. There's no soft spot there because everything is soft. So you should be able to feel with the needle where is the bone and where is the soft point where I'm going to make my portal. Knee with osteophytes sometimes. So when you enter with osteophyte, there's a big infrapatellar osteophyte. It wouldn't allow you to go. And if you have seen on the X-ray that there is osteophyte in this osteoarthritis, you would be a little more kind of cool, and you know there is a problem and I'll face it, because there can be a problem in entering this knee. Knees with flexion deformity. You can enter in the notch area, in the gutters, but you cannot go to the suprapatellar pouch unless the knee is completely straight. So I've seen my fellows struggling to go up into the suprapatellar pouch because they've not made their knee completely straight. It is bent and they're trying to go under the patella and they only end up scuffing the patella. So at that time, the knee has to be completely straight or rather hyperextension. If there's a flexion deformity, obviously that's not possible. And you have to use another portal like supralateral, supromedial if you want to see in the suprapatellar pouch. Big fat pad is a big problem for all of us. It is always big when you are a beginning surgeon, and then you know every fat pad is a small fat pad because you learn how to handle the fat pad. But you can sometimes see even on the MRI, it's a huge fat pad, and you can be a little bit mentally prepared. Then if there's a locked meniscus, often very difficult to enter the joint because locked meniscus doesn't let you see anything. And you must know if there's a bucket endal tear, which is into the intercondylar notch, then you know it is a problem. Initially, you may have to orient yourself properly because meniscus wouldn't let you see the medial condyle of femur and you know all the meniscus that you're used to. So that is a difficult entry again. Sometimes there's a big loose body right in the notch, and when you enter, you don't see anything because it's a loose body. It doesn't allow. And once you know on the X-ray that there's a loose body there, you know, and you know it is going to be a little bit of a tussle to enter the joint, but I know the reason and I will handle it. So once you know all these things, your performance increases. So I'm coming. It's a patience game. If there's anything on which you can lose your patience, your performance goes down, and the arthroscopy, all the equipment trolley starts laughing at you because they can see you struggling. Now, being able to switch portal is an important milestone in arthroscopy. So I think I'll repeat, this is very important for beginners. If you can switch portals at ease, effortlessly, you have learned arthroscopy, which means you can see inside the joint from different angles. Don't have that inhibition of just looking at it from one side. Sometimes you look at it from the other side, it looks different. So be easy to switch your portal. And what I have lately started doing is for the last few years, I use my shoulder set switching stick. As we switch portal in the shoulder, similarly, I switch portal in the knee as well. So I have to put the stick and just put my cannula over it. It takes away the struggle of unnecessarily hitting the capsule again and again. So this is wherever you have made a portal, if you want, you can leave a stick there. If you want to come back there, and your entering and re-entering will be very simple.
Sir,
so now, yeah.
Yeah, sir, Dr. Tejas has a query because some surgeons, they are doing a vertical portal, some surgeons, they are doing a horizontal portal. So what is your take on that? What are the pros and cons of each vertical and horizontal portals, or it's just a optional? You can do
Okay,
anything vertical or horizontal.
right. So there is one logic to this. It's not totally illogical. If it is a routine standard arthroscopy like a meniscus surgery, like a loose body removal, you make a portal in the middle of the soft spot, and you can, and I do, and you can, anybody can make a horizontal portal. The horizontal portal has one advantage, that it is cosmetically much better, right? Now, vertical portal has an advantage that if you're a little bit high or low, for example, particularly if you're working on the lateral meniscus, then you can just extend it a little bit up, little bit low. The disadvantage of vertical portal, on the other hand, is if you're not accurate, careful, you can cut the meniscus. Now, when you are working closer to the midline, which I always do when I'm doing ACL surgery, my portal is very, very close to the patellar tendon, almost sometimes through the patellar tendon, because I want to be as midline as possible, but that can help me to see my wall of the lateral condyle much better. So I don't see from medial portal, I continue to see from the lateral portal itself, but I've modified that portal far, towards the midline. So there I make a vertical portal, because I make a horizontal portal, I can cut the patellar tendon. So you can make mostly I make a horizontal portal, except when I'm too close to the patellar tendon. I think that is my choice between using a horizontal and a vertical portal. Anybody else, any comment? Dr. IPS, Dr. Pratik?
I think that's
Right?
perfect, sir. No, nothing to
Okay.
add.
Okay, so once you are in the joint, and as I told you, how do you get in and how it is difficult or easy to get in, you must
Satish
be.
has a question, sir. Satish, you can ask directly to sir. Satish.
Sir, while doing ACLR through the anteromedial portal, so do you do a two vertical portals or one single lower anteromedial horizontal portal?
So I make only two portals. I don't make three portals in ACL, because my viewing portal, the first portal is quite midline. Okay, that's why I told you. If I make three portal, if I make my standard portal for ACL also standard soft spot portal, then I will use two portals on the medial side, one high to see and one low to drill. But since I make my first portal quite midline, almost next to the patellar tendon, that need for making second portal, what is called high medial portal to see, is not required. And we have done a study on this, where there was a thesis given to one other fellow, and we have proven that it doesn't make any difference in terms of where we position the femoral tunnel. So if you make a portal on the medial side, two portals, obviously your low portal will be horizontal because you are very close to the meniscus, and your high portal, which are very close to the patellar tendon, will be vertical. So only when you're coming closer to patellar tendon, for whatever reason, your portal is vertical. Otherwise, horizontal portal works very well. It is very cosmetic.
Okay, sir. Thank you.
Right. So once you are in, you must see everything. And for seeing everywhere in life, you need a well-lighted area, well-lighted joint, and clear visibility. So once you go in, you find everything is hazy. There is something you're seeing, but you don't know. Either the light is not okay, your bulb is not on, or your light is not properly turned on, or you don't have a clear visibility because there's a lot of synovial fluid on some debris, and that's why you can't see. Now, if you want to see different parts of the joint, because you move with a scope, there are two important things a beginner should know. One is you maneuver your scope. Our scope has a 30-degree, viewing end. So once you turn the scope, you can see quite a bit by just turning the scope. So that is called maneuvering the scope. And I'll show you how you can maneuver the scope inside the joint and see different parts. More important, which I again don't see a lot of youngsters understanding, is positioning the knee. So when you are moving, when you are seeing, there are two things happening simultaneously. One is you are moving your scope left, right, up, down, in and out, and you are moving your cable to position your scope properly. And then you are positioning the knee as well. If you are seeing medial side, for example, you will manipulate valgus. If you are seeing lateral side, like that, varus. If you're seeing suprapatellar, extension. So it is a combined movement of your scope as well as positioning of the knee, which helps you to see different parts of the knee joint. So these two important maneuvers, initially you have to remember, later on becomes a part of your game. So if you're not seeing something properly, either your scope is not in the proper position, your cable is not in the proper position, or your knee is not in the proper position and you can't see. So whenever you're stuck, you're not able to see what you want to see, well-lighted joint, but you cannot see a part of the meniscus, for example, then there's something wrong. Either your cable is not correct, or your viewing the camera is not in the proper position, or your knee is not properly positioned to see that part. So these two things have to be remembered. Now, what are the maneuvering with the scope? For example, viewing angle. We know it is 30 degree, you can rotate it and you can see much more. Rather than a 0 degree scope, which will only see front, 30 degrees sees all over. Over a period of time, if you become an expert and there's a need, you can use a 70 degree scope. But that needs a little more orientation. You can move sideways slowly from left to right, which is like walking into the joint, from left to right and up and down, which is very simple when you want to see different parts. And you have to make picture in your mind. A, B, C, as you move, you can see the whole thing, which you're actually seeing in parts. But because you're moving slowly, you can create a picture in your mind, what exactly is happening. Zoom in and zoom out. Sometimes you're too close to a lesion and you cannot make out what it is. Particularly, for example, a loose body in the notch. You're too close and you don't know what this white thing is. And as soon as you zoom out a little bit, you can say there's a loose body. Even sometimes if you're too close to a meniscus flap, for example, it'll appear something very big, white thing. You don't know what it is. And as soon as you withdraw it, you find out, okay, it is a, flap of the meniscus. So zoom out, zoom in, sideways moving and rotating the angle of the viewing is going to help you. So this automatically, it's like, riding a cycle. Initially, when you're cycling, you know what to do, this, handle it properly and brake and this and that. After that, it becomes all automatic.
Sir, Tirath is raised his hand. Tirath, you can unmute and ask a question.
Yeah.
Yes, sir. My question is in continuation with the previous discussion only. Many a times patient complains paresthesia over the lateral portal. So anything related to the horizontal incision or vertical incision in that scenario, sir? What is your experience?
So as you know, the vertical incisions are more likely to cut all these subcutaneous nerves. Definitely, because they go in that direction. If you're making a horizontal portal, it is less likely to cut the nerve, but still you can cut. But important is, what is the portal, the purpose of the portal? I have to make vertical because that helps me to reach midline, right? So
Yes.
little bit one subcutaneous nerve cut here doesn't bother me, because I know what I want to see inside, so I have to go through that small cut based on what I want to see inside. So I agree with you that there may be some subcutaneous nerves cut in vertical portal more often than horizontal portal, but I don't think that's very significant or important.
Tejas, you have a question?
Yes, sir. Sir, my question is about this slide only, maneuvering the scope. Sometimes what happen in the very narrow or small knee, while we doing a zoom out, we are out of the portal and we again have to insert the scope and sheath and then so what is the tips and tricks by which we cannot doing that, we cannot getting out of the knee totally?
Yeah, so good question, particularly in the knee joint and also to some extent in the shoulder. When you're coming out and the scope is about 8 or 10 centimeter, then you have a telescope and then you have a camera. So everything is too long and you cannot really control it very finely going in and out. You can come out very quickly. So you use one finger of the left hand. When you're coming out, you put your camera is on your right hand, for example, for a right-handed person. You put one finger right at the entry where the scope is going in. So in a way, you guide your coming in and going out. So it's particularly going out, you have to be very, millimeter by millimeter. That's only possible if you're controlling it right at the entry point. If you're controlling it from the camera, sometimes, by the jerky movement, the thing can come out. So when you're coming out, control it with the help of the other hand. Does that answer?
Yes, sir. Yes, sir.
Makes sense. There is a question which has come in chat box, sir.
Yeah.
He says that when you are very, very close to the patellar tendon, as you said, how do you cheat the fat pad while entering it? Does the
Yeah,
fat
so
pad cause problem?
I'll come to that.
Okay, perfect.
I'll come to that. That is a part of the presentation. How do you cheat the fat pad?
Yeah, yeah.
Okay. So any other question?
Not yet, sir.
I have a question.
Yeah, please.
Suppose you are making a portal and the incision is bit large and there is lot of water being going out of the knee. So what to do in that scenario?
Okay, so obviously if you make a larger portal, water will flow out, and it does flow out, for example, in shoulder as well. Doesn't matter, you can just increase the pressure and you have to maintain a continuous inflow outflow. That's number one. If it is too much, sometimes you want better inflation, you can use a cannula. These days we have cannulas in the OT because shoulder arthroscopy is also done. Even if you're not doing shoulder arthroscopy, it's a good idea to keep some cannulas. Sometimes they're handy. At least they don't spoil your whole environment of the OT and too much fluid running here and there. So I think normally not much fluid comes out in the knee because there is a fat pad there. And more often than not, the fat pad stops from the fluid to come out. But sometimes, yes, it comes out from there. If it is small amount, it doesn't matter. If it is in large amount and it is bothering you, and I agree with you, in the beginning, sometimes all these things bother you and your performance level goes down from 100 to 95 just because too much water and you're not used to that kind of working. After some time, I have almost worked swimming in the water, pool of water. I don't even know what's happening in my foot. My foot may be completely covered. My clothes may be completely wet. But after some time, you don't know anything. You're just looking at the monitor and working. But initially, it matters. So if it is bothering you too much, you can always use a cannula. And beginners should use some kind of a system to stop bleeding water here and there because it does bother your performance.
Yeah, but they should not put finger over it. It becomes too much inflated. The swollen or the soft tissue. They should not stop the water coming out.
Yeah. So if it is, for example, suprapatellar pouch have these problems, and there you can put some cannula temporarily so that not too much water is flowing out everywhere.
Sir,
yeah,
if you
have a question, Patro.
Putting a stitch, is there any role of putting stitch and decreasing the wound size?
Yes.
Sorry?
Is there any role of putting a stitch and decreasing the incision size?
Yeah, if you've done the job, for example, you have to remove a big loose body, you have to make a big portal, you can put a stitch. But I'll tell you, the water will still come under the skin. That thing will blow up. So it doesn't work that way. So if it is a problem, I think better is to put a cannula inside. If you don't have a cannula, you can put the stitch. Water may not come out, but it will all accumulate under the skin. It will become a big bump there. Unless you close the capsule, which you cannot close.
Thank you, sir.
Okay,
right.
So let's proceed.
So we go next.
Yeah.
So, so this is about manipulation the knee. We know valgus force to open up the knee joint. You can have a side support here, or you can have somebody to press it here. Right. If your assistant is pressing, he has to press right at the knee joint, and then only your body can give a counter like this. And by doing that, you can open up the space, and all those so-called blind spots have not remained blind spots anymore because you can just manipulate the knee and open up like this. If it is really too tight, sometimes you can do pie crusting, but almost 90% time you can see it reasonably well. And pie crusting is more often required not to see, but to be able to work in that area. Sometimes your instruments don't reach whatever you do, so you have to do pie crusting, but that's an option on the medial side. On the lateral side, usually there is no problem. I normally use a varus by my body itself because I keep the knee in about 30-degree flexion and I just put my body here to give a varus stress. If it is comfortable, good enough. Otherwise, I tell my assistant to push from here. But in 30-degree, the advantage is there is a lot of flow of water inside. If I bent it, for example, cross leg like this, sometimes it is difficult to see because fat pad comes in the way. So I always find between figure of 4 position and varus in the body, this is much better for me. It gives me enough space without obstructing the vision. But as soon as you flex the knee, the fat pad comes and then you have to excise the fat pad first. But either of the two are good enough. I do it like this more often than not, and but both are okay. So what are the problems in seeing? So how to enter, you know how to manipulate, you know how the scope works, but then you have entered already and now you're seeing inside. What problems can we have? So first is fat pad. Fat pad is a friend of beginners. It'll always be there. And as you learn, you know how to cheat the fat pad. Now, one way to cheat the fat pad is you go, when you make entry point, your direction of entry should be 45 degree to the vertical. So you're not going like parallel to the coronal plane. You're going rather in the mid sagittal plane. We're entering wherever and try to hit the opposite condyle of the femur. So that means you are on the other side of the fat pad. Once you do that, you are actually behind the fat pad. That's how you cheat the fat pad. More often than not, you are actually under the fat pad or behind the fat pad. And then you come from there, and later on you can always excise the fat pad. So one is how do you enter, and you can cheat the, as you know, fat pad is biggest at the bottom. As you go up, it forms mucosum. So when you are high on the portal, for example, in ACL portal, you are much away from the fat pad because by that time the fat pad has become thin already. So if you are in the thin part of the fat pad, as well as you are at 45 degree, which means you are kind of avoiding the fat pad completely, and you are behind the fat pad when you are entering. That's how you cheat the fat pad. Now, once you are inside, then you have to detach the fat pad or excise the fat pad. Now, don't start excising the fat pad right in the bulk of fat pad. There will be no end to excising it. The best is to do it at the 12 o'clock position. And I'll show you this video. So you find this mucosum attachment at 12 o'clock. Either detach it with the help of a hand instrument. If you are new, it is always good to remove with a hand instrument because you're not sure whether shaver will work. You just remove this attachment of mucosum at 12 o'clock position, and because of the pressure of the fluid, the fat pad is pushed to the wall. That means anteriorly, and suddenly everything opens up. Or you take your scope, the shaver pointing up, and just detach the fat pad mucosum from this 12 o'clock position. As soon as you remove it from 12 o'clock position, you don't have to excise the fat pad. It gets pushed by the water. It's only in some surgeries like ACL, if you have to flex quite a bit, then you have to excise the fat pad. Otherwise, once you remove the fat pad from 12 o'clock position, the pressure of water itself pushes it away and it is sticking to the wall, the front wall behind. Now, if you want to remove more, you can always remove more now. But once you detach it, you can see the notch very well. Now, inflation of the joint is a very important learning point because very often we don't know why we are not able to see the too many tissues. I think best is to inflate the joint, whatever way you elevate your water bottle, or I showed this last time. I use this homemade pump. You can do whatever you are comfortable with, but just elevating the 6-liter bottle on a tall IV stand is good enough. But when you can't see, you are too much muddy and too much, things inside, just give it a good wash with a water flow. And once the joint, and you can see the joint blown up. If you can't see the joint blown up, something is wrong with your inflow-outflow system. So this happens. You have introduced the scope, and now you are happily expecting to see something bright on the screen, but you see blackout. You can't see anything. What has happened? So nobody can tell you. You have to know what has happened, why you can't see it. Now you look at the electrical system. So how will you see? Only when this has happened. The light source has to be switched on. The light has to go in. It has to then come through this and through the console and in the monitor. VK Rajan is talking. So if this system is not complete, you can't see it. You can only see it if your light source is on. So first check. So take out your scope, see there is a light there. Light there means your light source is okay. Then you are seeing inside, you see your console is on or your monitor. One of these things may be off and you can't see it. And it has happened one time that everything was okay. Light source was on, light was visible, console was on. And I realized that my scope lens has broken, which I probably didn't check before starting the case. So at the end, I found that my scope lens is not okay. And I had to use another lens. So if you know this algorithm, you'll find out what is the problem. Usually it is one of these switches not on, or they've got pulled out and you can't see it. Now,
Sir,
you
Tejas
see,
has a question.
Yeah.
Tejas, Tejas ask.
Yes, sir. For seeing properly, while inflow of the water or saline is good, is not good. But we put a holes of the top of the that 3 liter saline pints from by the needle, which comes with the TORP set.
Mhm.
When we put the hole and still we cannot see, we cannot use that inflation or BP cuff because of the holes. So
Yeah.
are you putting holes, or are you already using that BP cuff in all the patients?
So as you know, to tie a BP cuff on a 3 liter bottle is difficult. I've never done it. What I do is the kind of pump system I have made. So I let the water flow about 100 ml, and on top of 100 ml, I insert another TUR set, and I pump with the help of a BP cuff. And I can show you that. I showed it last time. I can show it again if I go back. That's how my pump system works. This is it. So if you see, there is a 2 water bottles and TUR set here, and then I have another TUR set. So
Okay.
these 2 are set, both the entries are going there in the air part of it, not in the water. And
Okay.
then I will show you how it works. A little bit care and training. So this 2 Y connection is going to my scope through this, which is, everybody knows it. This is the Y connection, and it is attached to my scope here. Now, either I get enough water, fine. If I don't, I want to flush. Then I have this connection also on the top. And then this is attached to a BP cuff. So my assistant will just push it a few times just to quickly send water in. So if he presses like this, if I'm seeing it is dirty and I'm impatient, I'll tell him to, okay, I want some pumping. So he will do a little bit pumping, the pressure will increase inside, and you will get water with more force. This is my jugaad, local jugaad. But you have to be
Sir,
careful about sterilization.
Sir, in
sir,
this
in case there is reverse flow, will it compromise the sterility of your procedure?
That is why sir said, no, you actually let 100 ml go first. Let the bottle, there will be air column above.
This what entry you are making in that
Yeah.
tube on the top,
Yeah.
that is unsterile. So we
Unsterile.
try everything, but it's still unsterile. It should
While
not touch water.
while putting the TUR also, you have to apply some kind of sterilium over that part, and then you pierce.
Yes. You're right. All that. So that there's a little bit of a compromise of sterility here even then. But if you have trained one person, he does it. If you're a new person,
Yes.
he doesn't know. So sometimes obviously lately we don't even use this, because we use pump and patient pays for it. But I think this is a very economical way of doing it. In case you are in a problem, just keep it. You may not need it at all, but just keep it there in case in between you are stuck and you want some fast, there's some bleeding and you don't want to wait so long, you can just pump it and do it quickly. But if you are patient and just a IV stand and a height is good enough. And if you have a special IV stand which can be raised very, very much up, it is good. But most of the IV stands don't go so much up and they become unstable, they can fall, and that's an issue.
sir,
All right.
you
Regarding pipe resting, sorry. Yeah.
Tejas.
Ranjit, please.
Tejas is asking.
Tejas, yeah.
Yeah.
sir, you open both saline bottles simultaneously or one by one?
One by one. But they are both ready because
Sir, on a pike resting,
yeah, just let me complete
sorry.
that. They're both ready. It depends on what kind of
Yes,
surgery
sure.
I'm doing. If it is simple arthroscopy, meniscus, I just use one bottle. But if it is to ACL, for example, I keep 2 bottles because I don't want them to take time to change. So while one is gone, the second is they're putting second, at least the other one is already on. So it's just to save time.
Okay, sir.
Sir, Paras is a question regarding pike resting. Where exactly do you do it? At joint level or on the tibial part or on the femur?
Yeah, at joint level. So I put a needle from outside in, which comes in just above the meniscus, and I can see the needle. Now that's my point. I take out the needle and just about that area, gently pike rest by changing the direction of the needle and start applying a valgus force. So I do it right at the joint line. So we go to next, which is read out.
Yes, sir. Yes, sir.
And
Yes,
that's
sir.
what you see very often. Often it is blood. We wash out and everything is clean. But sometimes you wash out everything, but that red thing is not going because a clot is stuck on the lens. So that day, so this happens very commonly, and you just flush some more, wait for some time, and maybe take out your telescope and let the water flow out from your cannula itself, which is a faster one. Some of the clots will come out only through the cannula if you have removed the telescope. They will not come out through your normal portal or even your cannula portal, but you have to remove the scope and get the, flush out the clots. So that's one thing required. So you check, first of all, as soon as you get a red out, you check whether the water is flowing in. It should not normally become so red unless there is enough. If there's enough inflow, outflow, so much bleeding will never happen, more or less. So check water. If the water flow is stopped because it stops and nobody takes care in the OT, suddenly the water is gone and you'll find it is all bleeding inside. Then you check your tourniquet. If you're using in the knee, tourniquet may suddenly go off and starts bleeding. Though we can do arthroscopy of the knee without tourniquet, it's a question of time. It keeps bleeding, it washes, but after some time, everything becomes stable. So check water first, check tourniquet if you're using tourniquet every day, and then start washing it out. Use a wide bore cannula. That means you remove the, your inflow is going from the camera, from the telescope portal. That you cannot, but you have to create another wide bore outflow cannula in the suprapatellar pouch and wash it. It's not required usually, you just wash it out inside out through the other portal. So if you have an anterolateral portal from where the inflow is happening, you can put a wide bore cannula of some kind through the anteromedial portal and then give it a wash. And sometimes the clots are too many and you are just spending time, they're not coming out, and they're all the time, because if there are clots inside, they keep throwing red water or the blood and it keeps making it hazy. So unless clots come out, your red out does not go completely. And sometimes you have to actually use a shaver to get the clots out. Otherwise, it doesn't become clean just by washing also, because there are clots inside. So these are the different ways where you can actually clear the red out and let you see things properly. And of course, patience is required. Sometimes this is what happens. You are seeing something white, you don't know where you are. And the reason could be you're too close to a tissue. For example, you're too close to a cartilage, you're too close to the capsule, and everything is white. You don't know where you are. And as you withdraw the scope, you start seeing. Slowly start withdrawing. You're too close to the fat pad. It will also look like this. So just start withdrawing slowly and you will start seeing where you are. Sometimes the light is too bright and the reflection of the light is too bright, and even whatever you are seeing appears white because the reflection is so much. So then you can check the light source and you can reduce the light amount, and that can make you see things properly.
Sir, Amol has a question. Amol,
yeah.
Sir, about tourniquet, what is the threshold of any thigh circumference or weight that beyond which you don't apply tourniquet, or what is your criteria regarding applying threshold, or every case you apply? Or
I think beginners, I would advise use tourniquet always.
And when to not use it, about what level of weight or thigh circumference?
Nothing. If you have a good enough tourniquet and a fat patient and your tourniquet is a good size, you use it. If your tourniquet is not fitting the patient, of course you can't use it.
And
my answer is
300, 350.
Sorry? Say again?
Is there any
Okay, yes, sir, I got it.
for tourniquet placements?
Sorry?
Is there any contraindication for a tourniquet? Like they say that on an X-ray of the knee joint, if you see that there is a calcification in the posterior artery,
yeah,
or any calcification above, and then you can get into trouble or some thrombosis.
Yeah, so I agree with you. Theoretically, in those situations, you should not use tourniquet, like we don't use in knee replacement in those situations. But it is a balance between how difficult it is going to make your surgery vis-a-vis, causing complication because of that. I've used tourniquet in the presence of almost, visibly sclerotic vessels in the leg. Nothing really happens. But I know when you're doing open surgery, you don't use tourniquet, it doesn't bother you because it's bleeding a little bit. Suppose you're doing arthroscopic surgery to prevent that so-called complication of an atherosclerotic vessel, and it starts bleeding and you can't see anything. What is the point? So over a period of time, you get used to working without a tourniquet, which is fine. But if you are a beginning surgeon, rather than trying to save that complication of a vascular injury, which is, to my mind, quite theoretical, and it makes your whole procedure very difficult. Because arthroscopy is dependent on visibility. If you can't see, you can't see. So in that case, if you are really concerned, be prepared that you will work without a tourniquet, but you will struggle. If you are okay struggling, it's okay not to use a tourniquet. I'll still apply a tourniquet there and try to avoid using a tourniquet. But if I'm struggling and I have to do that arthroscopic surgery that way, I'll put a tourniquet on. I think, yes, there is a theoretical risk of blocking the vessel, but in my opinion, it is theoretical. It really doesn't happen.
Yeah, Dr. Akshay has a question. Dr. Akshay?
Yeah.
Dr. Akshay? You
Akshay,
can ask your question directly. You can unmute and ask the question. And Dr. Tejas has a question. Dr.
Yeah.
Tejas?
Yes, sir. Sir, while we cannot see or cannot view properly and everything is okay, so is there any concern with the sheath? Sometimes some surgeon says use high flow sheath or low flow sheath. So what is the difference actually between high flow and low flow and all these other different type of sheaths?
Okay, so yeah, so there are new designs of sheath which are high flow because they are broader, and when you use a IV set, more water comes in, obviously. But if you are using some kind of a pump or you are using a elevation, I don't think, at least in knee surgery, it doesn't make so much difference. Because once you are doing a tourniquet, and we have done arthroscopy for years with a low flow sheet, I don't think it made any difference to my arthroscopy because I knew how to inflate the knee even with a low flow. And I know there is no bleeding, so high flow, low flow really doesn't matter in the knee, I would say. In the shoulder, it does matter because you need good flow all the time because there is more often chances of bleeding in the shoulder. But in the knee, and I have done, first 20 years of my life, I've used only low flow. But we know how to increase the flow even in low flow, like increase the pressure.
Okay, sir.
Sir, regarding the tourniquet, sometimes what happens while draping, we use the towel clip and kind of thing, or sometimes the tourniquet itself is leaking tourniquet, which has been tied up. So we end up in a tourniquet with the incomplete pressure, and that is very dangerous because it becomes a venous tourniquet.
Yeah.
And whatever you do, the bleeding continuously goes on unless you disconnect that tourniquet, completely deflate it, or reapply a new tourniquet. So what is your
so this happens in every surgery that you do under tourniquet. Sometimes tourniquet is not effective, even open surgery. For whatever reason the tourniquet is not effective, or if it is partially inflated, you are seeing too much bleeding, obviously you deflate the tourniquet first. You deflate the tourniquet, elevate the limb again, inflate the tourniquet again. If it doesn't work, there's something wrong with that tourniquet. Then you obviously have taped everything. If it is very critical for you to use tourniquet in that surgery, which is not the case with arthroscopy or even any open surgery you can do without tourniquet, you will go ahead. If you think no, tourniquet is very important, like you're doing, some nerve reconstruction or, you're doing something else, then of course you'll have to undrape and maybe use another tourniquet. And we don't have sterile tourniquets available very freely these days. So otherwise, if the tourniquet is necessary, you'll have to more or less undrape and do it again. But in arthroscopy, I've learned over the years, and of course now we do without tourniquet. You can do knee arthroscopy without tourniquet. Just don't lose your heart. If your tourniquet is not working, deflate it, wait for some time, wash out. There will be initial bleeding for 10-15 minutes, but after that, everything will settle down.
Yeah,
So regarding the visualization, I have a question.
Yeah.
Many a times freshers start arthroscopy and they get lost in the fat pad. And then suddenly they see the ligamentum mucosum and they think that it is the cruciate ligament. And many a times I get a call saying that there is a cruciate ligament injury that requires a reconstruction. Number one. So do we have, and the second thing is that sometimes with the locked bucket handle tears, the mobility of the knee is not too much. They're not able to flex and get the scope into the joint.
Yeah.
So do we have some tricks that we could teach them?
So your first point that...
First is about the ligamentum, sir.
Yeah.
Which is confused with the cruciate ligament.
Yeah, so I think that's a little bit of a learning curve issue, and you should be able to only start looking at the knee completely once you can see the notch of the joint. So as I discussed in the last presentation, you from medial meniscus, medial condyle of femur, you follow the notch. Once you follow the notch, medial part of it, as soon as you come in the middle part of the notch, you'll have a confusion because there'll be a mucosum, ligamentum mucosum. Because you're following the notch. Once you're following the notch, you again cheat the ligamentum mucosum because you move over it. And you move over it and come to the lateral side. Now, there is no question of anything here because you are actually moving along the notch and your cruciate is all inside the notch. And then at 12 o'clock, there is some funny tissue which is not letting you see inside. That is what mucosum is. Then you bring your instrument from the other side and detach the mucosum, which is attached very, very superficially. It is very superficial. Your ACL on the femur is all the way back. You can never kind of see it so easily.
Perfect.
So
Yes.
basically, if you are seeing something very quick and easy, it may not be ACL. It may be very, very superficial, which is usually mucosum. And unless you have seen all the notch in one paranomic view, you have not removed enough fat pad. You will struggle.
Right. Yes, sir.
So once you have removed the 12 o'clock fat pad, as I showed you, as soon as water comes in, you can see the whole notch in one view. If you can see that, enough fat pad has been removed in more often than not, except in ACL, we have to flex more, then you have to remove more fat pad. In other surgeries, you don't need to remove any other fat pad. Just detach it from the 12 o'clock position, and with water pressure, everything becomes visible.
Yes. So the other part about the locked meniscus.
Right. Right. So once there is a locked meniscus, it does obstruct because you are in a flexion deformity sometime 10, 15 degree. And then you know that there is a locked meniscus, you can make your initial portus slightly higher. And then, of course, if it is a medial meniscus, it doesn't need any change. You can go through same, except that when you enter, you will not see what you're expecting to see. You will not see the medial condyle of femur. You will not see the medial meniscus border because it's all displaced in the notch. But that's a mental preparation that you will not see the way you see it normally. For a lateral meniscus, if there's a buccal tear and I know on pre-op MRI, then I go slightly high because I know otherwise I can't even enter sometime. So that's all your mental preparation based on your MRI assessment. So if you know there's a locked meniscus, you know it is going to be a little bit difficult to enter, but you know it, so it will be easy because you know it is going to be difficult.
Thank you, sir.
Right? And those are a little bit of a learning curve as you do more and so as long as you know the trouble doesn't happen. It only happens when you don't know the trouble. So it's best to orient yourself beforehand that this is what problem I'm likely to face in this case. Now this is fogging, which we discussed last time also, very common. Yes. And once it happens, one thing you can do is you can, open everything, and I use a cover, and I have to remove the cover, clean up everything. Now lately I've learned this technique of using a suction. So I make a small puncture in my polythene cover and insert a suction tube and seal it to the polythene cover with the help of tape. And then whenever there's a fogging, I put suction on and the fogging disappears. So that's one way you can do it, but don't struggle. If it is fogging, we have a tendency to continue to do it. And let me tell you, as soon as you can't see it properly, your gray matter becomes from 100 to 90, 90 to 80, and you're likely to commit another mistake. Be patient, clean it up. Even if you take 10 minutes extra, you must see inside. Otherwise, you cannot do it. Even the best surgeons will struggle inside and you may do something wrong. So in arthroscopy, the principle is stop if you have a problem. Think why the problem is. Sort out the problem and then move forward. It's not like open surgery that if you don't have an osteotome, you can use chisel and do the same job. It doesn't happen that way in arthroscopy. So sometimes the tissue is stuck on the lens like this. You've cleaned everything, good water flowing, you're moving, and there's something hazy there which is not allowing you to see everything. Now you don't know why this bloody thing is not going away because it is stuck to the tip of your lens. So you have to take out your scope, clean up the lens and put it again, and it becomes okay. So this is what happens. Now you can see, but it is hazy. The reason could be water is not on. So first of all, check whether the water is on. One way to check is to see whether the knee is inflated or not. Second, you can always close your inflow and open your outflow and check whether the water is there. And second, of course, whether the water bottle is empty. Now, there may be blood, which may be, little blood, which is hazy. It is not really blood as read out, but blood is making everything hazy, which is a question of just washing it out. Sometimes there's a blood clot inside, which you have missed, and that blood clot keeps throwing RBCs and keeps making it hazy. So once it is washed out, but it is not getting cleared, you know there is a blood clot sitting somewhere. Either you find it or remove your scope, let the cannula, big cannula at the scope, wash out everything, and you must get the clot out. Sometimes you can actually see the clot, and as I told you, you can introduce the shaver and suck it out. Now, synovial fluid, sometimes in arthritic knees or synovitic knees, itself is a very big reason for haziness. It takes a little while to wash out the synovial fluid, and then only you can see clearly, because now it is all water inside and not the fluid. Sometimes you need more light, because somehow if the cartilage is not bright and it is all arthritic knee, the reflection of the light is not there from the different surfaces, and then you have to increase your light. This happens very often when you're looking in the suprapatellar pouch, where there's a lot of synovitis. It doesn't reflect light anymore, so you have to increase your light source so that you can see it better. And of course, sometimes it is hazy. That means your lens is defective. There's some scratches have happened on the lens, and you can open it, then see. And that may be sometimes detected only while you put the scope in, unfortunately so, and you may have to see it or maybe struggle or maybe change the scope. Now, second thing when you can see is orientation. Now, a beginner will definitely put the scope in. You can see everything. It's looking very bright, very nice, but I don't know what is there inside when I'm seeing. So now the question comes, how do you orient yourself, what you're seeing? And two culprits which disturb your orientation are these. One is the camera, because if the camera twists, it has to be looking up. Every camera has a system to tell you how to hold the camera with your right hand, which is the top side, which is the bottom side of the camera. You should know. And the cable. If your cable is looking like this, you will see exactly what inside. If the cable turns around while you are looking at the monitor, sometimes because the gravity, the cable actually rotates. Now you are not keeping an eye on this. So this part of the cable sometimes can become vertical. Now you're trying to look at medial meniscus, but it is looking up. So you can't see the medial meniscus. So when you can't orient, check. Your camera is in the right position and your cable is in the right position. Then you will see exactly what you see by open in that area. So if I open up the knee, this is what I'm going to see. So if my camera and my light source are in the proper direction, I'll see exactly what I'll see if I do an orthotomy in that area. So that is one point to orient yourself. Now, second point is once you orient, you know what is meniscus, you know what is ACL. Now you want to put another instrument inside. So immediately you put the instrument, you can't even see the instrument. And that's what we call triangulation. And I said last time, difficulties happen. The beginners can't see the instrument at all. They're always moving here and there. They can't see the instrument where it is. And so that means they're not kind of skilled with triangulation. So what do you do initially? So I tell them, don't look at the monitor. First, look at your instruments. Your scope and your instrument should be joining together inside. You have to imagine. If they're not in the same plane, they're not making a triangle, you will never see them on the monitor. The problem is you look at the monitor and you're working with it. And you don't even know that the scope and the instrument are looking left and right. They're not in the same direction. They're not making a triangle. If they not make a triangle, you cannot see it on the scope, on the monitor. So you see from outside. Don't see on the monitor, but see from outside. Second, see where the light is. So if I see the light is here, I know I'm in the lateral compartment or lateral gutter. If my scope and the instrument both are not pointing toward that light, I will never see my instrument. So your light will tell you where you are, and the instrument should go exactly in that direction, trying to reach that light. And then you're going to be in the right place. Then you touch the scope with the instrument. Sometimes there's too much synovitis, you can't see anything, the joint is inflated. Then you touch the scope and move distally. Touch the scope. This happens, as I told last time, in subacromial space, you can't see anything. Just touch the scope, gradually move in front like this, And once you can see the thing, particularly with a shaver, you can do this. You can start shaving a little bit slowly. Everything opens up more and more, and then you can see it better and better. So these are the three techniques by which you can improve your triangulation whenever you're lost. Next thing I want to say, and it's not written here, is there are some familiar areas. For example, in the knee, the notch is a familiar area. That's the only space in the knee where everything will go easily. So if you're not finding an instrument, it is always lying in the notch. So go to the notch, you'll find it somewhere. And in the suprapatellar pouch again, if you have an extension, you will go somewhere in the gutter. So if you're working the suprapatellar pouch, you can't see the instrument, look into the gutter, mostly lateral gutter, you'll find your instrument there. So these are the different ways which remind you initially how to triangulate if you cannot see your instrument properly. These are the 4 different ways you can use, and gradually it will become a part of your habit. So now you can't reach posteromedial. So after some stage, you like to do posteromedial and posterior compartment arthroscopy, and it is a little bit of a learning curve. The first thing is how to enter posteromedial compartment. If it is easy, it is a young, healthy knee, no problem. There's a lot of space there, but sometimes there's synovitis, sometimes there's osteoarthritis, and you cannot enter the posterior medial compartment. You're seeing from the lateral side, you want to enter medial to the PCL, between the PCL and the medial condyle, but there's no space. So what I do is I shave a part of with synovium there. So I use my shaver facing down so that I don't cut the PCL and remove whatever synovium I can remove that area. I even sometimes shave off the eminence, tibial eminence, with the help of a burr. That's not important. I want to enter there. I want to create more space. Even sometimes I use a RF probe to create a kind of a round burn, very carefully saving my PCL. And I create a lot of space. And sometimes I see from the opposite portal what's happening. Why can I not go in? But more often than not, once I've created enough space, I again use my switching stick first, which goes very easily. And then if I want to go in that portion, over the switching stick, I take my scope. I bring my scope from this side, go over the switching stick. So you can use your switching stick to guide your cannula where you want to go, posteromedial portal, for example. So these are the tips you can use if you're not able to enter posterior medial portal, because if you can't see the posteromedial side, you cannot make posteromedial portal without seeing. So it is important to enter, and these are the problems you face while even trying to enter the posterior medial compartment. So this is one video like this, and you can see that there's a light there. First of all, your camera is showing there. I don't think it moves, but I showed last time that once you see there, you're in the posteromedial, you pinch there, and you can put a needle, then you put your cannula on top of it, then along the posterior condyles of femur, take a switching stick all the way laterally, and this is, I think, lateral side, so this is not accurate, but I discussed last time how to make posteromedial and posterolateral portals, and then you can do posterior arthroscopy with the help of 2 posterior portals, one for seeing and one for working. Use cannulas on both the sides. I think that's about problems in arthroscopy, and we can have some comments, some more discussion, and then I can go to complications. Anybody, any comments? Any more problem that you would like to bring it to attention?
Okay.
This was a fancy slide I was going to make. I couldn't make it, so I stopped it. I was trying
for the beginners who are just out after residency and they have attended a fellowship program.
So there is one thing. Yeah, Aslam.
Yes,
Aslam, please.
Yeah, this is regard the freshers who are just out after a fellowship and they are looking to buy their instruments. So would you guide them as to what instruments they should buy initially and then gradually equip themselves with more expensive equipment at a later date?
Yeah. So let me go back 30 years when I started my arthroscopy. And very early, I realized if I want to do arthroscopy seriously, I have to have all equipment. It is not that I'm saying it because I can afford it, but you have to have all instruments, whether you buy it or you loan it or you do what you like. But don't think that you can start with some little instruments first and then you can buy as it goes. Even if you don't buy initially, from whichever company you have bought your basic arthroscopy set, have a deal with them that you will need XYZ instruments on loan whenever you do arthroscopy. But don't try to do arthroscopy. So I remember initially when we were like very, very early in arthroscopy, the companies wanted to sell their product. And they would come and tell us, don't need to buy the shaver system. It's okay to buy scope, some 4-hand instrument, and some grasper. And Dr.
Exactly.
Maheshwari, this is like 2 lakh rupees and you buy it. And they actually fooled us because they want to sell you something which you will buy. If they tell you you buy the whole thing and it is going to cost you 7 lakhs, I don't know how much it costs now, you will not buy it. So they try to fool you into buying something ताकि उनका कुछ बिक तो जाए कम से कम. So that's not correct. You must have all equipment. It's a very equipment dependent surgery. Don't do it if you don't have the equipment. You have some of your own, fine. You can't buy everything in the beginning, but arrange the other one. Maybe borrow from a friend, maybe take a loan from the company, maybe use a local one initially, which work also very well. But eventually, if you have a serious arthroscopist, you will need everything. I think more often than not, why people have given up arthroscopy is because they struggle. And they struggle because they don't have right equipment.
Absolutely right.
Yeah, sir. Dr. Satish is asking, what do you do for tight lateral compartment? Only you are doing figure of 4 or any other tips for tight lateral compartment?
No, figure of 4 is good enough for tight lateral compartment. I don't think you ever have to do anything else.
Okay.
Anything in your mind? Is there anything that somebody wants to tell about lateral compartment?
Yeah, some surgeons, they put a myo trolley so that they can get the elevation to keep that leg in the figure of 4 position over the myo trolley, so that you can push more and to open up.
So you can open more. Yeah, sometime that is done because you want to open more. So you put something under the foot, maybe some big folded towel, so that you can press better. I have never needed it. And I find even 30-40 degree of flexion gives me good enough space to go in. If your instrument is going in the proper direction, which is very critical in lateral compartment, you really don't have to force it open so much. It is a question of you getting the instrument in the right direction, which you do with the help of a needle. If your instrument direction is not okay, then you have to really put a lot of pressure because you want more space.
Yes.
So I have never had to use things like that. I think maybe once in a while, very, very rarely.
I think
Dr. Swarnendu and Dr. IPS.
Maheshwari sir, may I add one point on the tight lateral compartment?
Yes.
Thing is that when you struggle on the lateral compartment, probably your primary thing you look that your portal on the medial portal is wrong. Either it is higher side.
Yes.
Because portal is higher on the medial side, then only you struggle. Opening on the lateral side, whether you keep on your Mayo trolley or else you put something on that, if you just flex it at 30-40 degree and somebody is pressing on the medial condyle of the femur, it should be on the femur at the lower half. It is never a problem. Only problem if your portal is high up, then only you cannot reach the lateral compartment. Lateral compartment is never tight.
Yeah, it is quite open because we can produce so much lateral opening even in a normal knee. It's not usually a problem.
Okay.
Yes,
yeah, Dr. Vishnu.
Vishnu is waiting. Yeah.
Sir, I have a question.
Yeah.
During triangulation, sometimes we find that the ligament of mucosum is completely dividing the joint into 2 halves.
Yes.
So in such scenario, how to manage? Actually, in my practice, I've just seen one case. Actually, so that's the thing when I understood that the ligament of mucosum is totally dividing the joint into 2 halves. So in one side the scope was there, other side my probe was there. So I'm not able to triangulate. So in such scenario, what is your step, sir?
Yeah, good point. Good point. So as I told you that I don't go from lateral to medial or say medial to lateral on the other side. I don't go horizontally. I go along the notch. If you follow the notch, you are cheating everything. You're going above the notch like this, and then everything is under you. And then you can start removing at a low clock position. Suppose still there is a problem. Sometimes it's not that easy to even see the notch. You go in the extend your knee, withdraw your scope and go to the suprapatellar pouch. And from there you come down. And then you have triangulated your instrument in the suprapatellar pouch. Your shaver is visible. Bring it down and then start removing the mucosum. And obviously, even if it is full anterior posterior mucosum, with a shaver, you can gradually remove it.
Yes, doctor, you will face this sort of trouble in two situations. One is the thick ligamentum mucosum, and another one is a big medial plica. Sometimes you cannot come on the medial side. So always the Maheshwari has told you a gem that whenever you are struggle that you cannot triangulate at the intercondyle area, this is for the juniors. They will always triangulate from the superior pouch. If you go to the your suprapatellar pouch and triangulate that, come down and shave off gradually, then only you will be able to see something on the notch. Otherwise, you won't be able to, because if you try for half an hour, you won't be able to see the other instrument. Am I correct, sir?
Yes, correct.
Thank you, sir.
You
Thank
have
you.
to identify the familiar areas where it is easy to triangulate because there is a lot of space. In suprapatellar pouch, even if you are somewhere near the scope and you move your instrument, it will be visible suddenly. And once it is visible in front of your eyes, then move both the things together wherever you want to go. They will move together like this.
Yeah, Binay, you have a question? Dr. Binay?
I have another question.
Yes,
Okay.
Vishnu.
Okay.
Sir, sometimes the fluid extravasates to the lower part of the thigh, even though we have not punctured the suprapatellar pouch. So what could be the reason in such scenario?
Very common scenario.
Why? But why it happens? But we have not gone to puncture the suprapatellar pouch. So from which place the water is actually percolating to the lower part of the thigh?
So from where it will go? From the fluid inside the joint, it will come out of the capsule. Now between the capsule and skin is the plane.
Yes.
It can go anywhere. It can come out straight away and flow on the water on the floor, or it can go anywhere. So that is these are the, between the skin and the capsule, there is a space. From there, it can move anywhere.
So, but the calf is normal. Only the swelling is in the lower part of the thigh. So I think
I will tell you why this is a problem with the juniors. Whenever you try to put fast your scope, you primarily go into the suprapatellar pouch.
Puncture it.
And then you puncture it, you don't recognize that it has punctured it.
Okay.
So that's why when you go into the suprapatellar pouch, don't try to negotiate your whole shaft of your obturator into the suprapatellar pouch. Try to be in the midline, just under the patella. Try to float it just below the patella and never forces the whole shaft. Because by the way, you puncture at one point in the suprapatellar pouch, which immediately when you take out your obturator, it closes. You will never recognize that there is a puncture of 4 millimeter. Whenever you press your fluid, flex and extend, that fluid goes from there.
Yes.
Okay, that is the explanation.
Yeah, that's a good point. That's a good point. Yeah.
Rajul, you have a question?
This is for the juniors. All the James we are opening for you.
Rajul Shah, you have a question?
Yes, sir.
Yeah, ask, please.
Yes,
how much pressure is required for the saver? Any tips for the how to use the saver correctly?
No, your voice is crackling. We cannot hear you.
Not clear. Not clear.
Come to closer to your mic.
How to use saver? Any tips for how much pressure is required for the saver?
How to use shaver effectively, sir?
RPM. It is RPM. It is not pressure.
Yeah.
Sorry, RPM.
Yeah. So usually it is 1500 RPM. I think that's what I use all the time, and obviously in oscillating mode. And anything, Dr. Samantha?
The thing is that you have the saver power in some system. It is up 5,000. So try to be in between. In the striker system, it is like around 3,000. So that varies from one motor to the other motor. But usually when you save off, try to be on the higher side. And the main trick, I will tell you for the juniors, always the saver, the cutting edge should be towards your lens, never away from the lens. Because if you away from the lens, you will abrade the cartilage. But it should not be very close to the lens, so that otherwise you will abrade the lens and every time you will injure the lens. So this is a fine trick between your wife and girlfriend.
Sir, Nikunj Agarwal has a question. Sir, what is your advice of the medial portal, your site for ACL reconstruction and to work for posterior horn or medial meniscus? So do you alter your portal?
So,
medial.
Yeah, so
medial
as portal. I told last time, there is no fixed site for medial portal. Or actually, there is no fixed site for any portal for the instrument. It is to be decided by the needle, depending on what you are going to do, which part of the joint you're going to, because Viewing portal is no problem. You can just sit anywhere in the center of the knee, rotate your scope, and you will see everywhere, left, right. But instrument portal has to be very specific. Once you have identified which is the area of interest, then put a needle. If your needle can go there, then your portal is right. So there is no fixed spot. For example, when we do ACL and we do ACL through medial portal technique, we first put in a needle and see whether my needle is going exactly where I want to make my tunnel and it is not damaging my medial condyle of femur, and then I go and make a portal there. So second portal is no fixed portal. It all depends on where you're going to work. For example, if you're going to work on posterior horn or medial meniscus, then you have to put a needle a little more medially to see it can go directly there, just parallel to the plane of the tibial plateau. If you're too much up and down, you cannot reach all the way posterior. And don't hesitate to put needle 1, 2, 3, 10 times. And even if by mistake you make it a wrong portal and you're struggling, come out, make another portal. Even 2-3 meters away from the previous portal, it doesn't matter. But if you struggle and you scratch the cartilage, you will end up with more damage.
The pathology will dictate your second portal. Never be committed with the second portal. Only primary portal probably I change when I do the PCL. Because when you do the PCL, your PCL portal should be a bit higher, like not like the ACL portal, because you have to see on the backside. Unless you are really trained to go on the backside. Even if you go the posterior medial portal, still you make your PCL portal till bit superior. But the ACL portal and PCL portal all are very close to the patellar tendon. But the pathology will dictate your instrument portal, because instrument portal is always, most of the time, it is from the medial side. But remember that whenever you are finding that the MRI, that you have to do something with the lateral meniscus, please never do it bit high up, because if you do it high up, you will never reach the target.
Okay.
Yeah,
And
Dr.
also to access the posterior horn of the menisci, your instruments have to come from the same side. So suppose I'm seeing from anterolateral portal and I have to work on the posterior horn of lateral meniscus, I have to come back and see from the medial side or put my instruments from the lateral side. Usually we work on the medial meniscus, so there is no problem. Because we are seeing from the lateral side, medial meniscus, you can reach posterior horn because you're on the medial side. But sometimes when you're working on the lateral meniscus and you try to bring your instrument from the medial side, try to reach the posterior horn of metal meniscus, it's very difficult. So there's a spine, there are intercondylar notches, and then you can't reach, you struggle. So take out your scope, see from the medial side. So for accessing posterior horns, your instruments have to come from the same side. So a little bit of switching of portals is required. As I told you right in the beginning, that's a very important milestone in learning arthroscopy. You should have no inhibition about taking the scope out, taking it in on the other portal, bring your instrument from here. If that is what you have learned, I think that's a very important milestone.
Posterior horn lateral meniscus for the juniors, never try from the medial portal. You will never be able to do it, or else you will take off the root, because you have to climb the two hills on the spines. That's why your whatever, even if you use the bend, they carved your meniscal point, still you won't be able to reach there.
Yeah.
So it should be your weaving should be on the medial side and portal should be on the lateral side. It just takes 30 seconds to balance all these meniscus.
Yeah.
Yeah, Dr. Binay.
Yes,
sir. So any tips on anybody who is going to negotiate a stiff knee? How to see inside a knee? Once you've gone in, don't see anything.
Stiff knee is a big topic. I think Maheshwari sir should answer first, then only we can take part. I will take
Maheshwari sir, anything specific about
So
visualization and a stiff knee? How to see anatomy?
So I can give a quick answer, but I think there is a need for one full webinar on this, how to do arthrolysis. It's a very tricky operation and no two arthrolysis are similar. So I would say, first of all, you go in the more familiar area. So in a stiff knee, I always go in the superolateral portal first. It's a too stiff a knee, because flexion, if there's no flexion possible, and I know a lot of things may be scarred, in the front of the knee, I cannot play blind. I can play blind in suprapatellar pouch. So I can go suprapatellar pouch and hit the patella, which I can feel. And similarly, I can go from medial side and create some space. Once I create some space, I have some orientation, then I go with the needle from the anterolateral portal. So actually I go reverse. So I would say there's a hidden trial in stiff release. They are all different, and sometimes you go straight from lateral side, sometimes you go suprapatellar. But if it's a very stiff knee, my first portal is supralateral, and that's where I'm entering blind more or less with the help of my cannula. Sometimes I don't even put my scope. I move my cannula left and right and create some space, because even if I put my scope, I'll see nothing. So that way you create some space, then you see, okay, you are inside the joint at least. Then you take another portal from the medial side, again with the hit the portal, hit the scope technique, and then you bring your shoulder, open up a little bit, then you can go anterolateral. And so it's a very, very difficult subject. I think it varies from case to case.
So that is the reason, sir. We on Thursday we are launching the video of Dr. Bhasin, and he is got techniques of arthrolysis.
Yeah.
I mean, that's around 30 minutes video, and I think it will answer all the questions. Which
I think we can. It's a good topic to be discussed in detail, because more or less an advanced level of knee arthroscopy.
Yeah. So this is one which we are doing.
If
I think somebody has raised the hand. Tirath, yes.
Yeah, sir. I want to ask if we want to bite anterior horn of, let's say, medial or lateral meniscus, then where should we take the portal? Because sometimes with the angled punch also we are not able to take bite. So any tips and tricks to take such bite?
You have to come from the other side, and if you have the luxury of having 90 degree, that is the best. If you have to, if you have the 90-degree punch, then not it is the best, or else you can have the saver. Even you will be lucky to have the carb saver, because anterior extreme end of the anterior port, if you do from the same portal, you will take off the whole intermeniscal ligament, and you will take off your anterior meniscal connection. So that is very dangerous. So you have to come from the other side, otherwise you cannot do it.
So sometimes ACL comes in between while we come from the opposite side.
No, ACL cannot come in between, because ACL only at that moment is. So I would give you my tip. I don't hesitate to make another portal. So when you are seeing anterior horn, your instruments have to come almost, you can say, parallel to the front of the knee, more or less parallel. I understand. So it is very difficult. You can come to middle of the meniscus, but your instrument doesn't go to the anterior horn. So you have to actually take a needle again and see how far medial or how far lateral can you go to get your needle more or less where you want to reach. That is one way. You may use a 90-degree cutter, but sometimes it's very difficult again to use it. And I have those, but they don't work. So what I've started also doing is I use my RF device very often for anterior horn. Then you try using this. If you have a shoulder set and you have an RF device, it is right there, because RF device works very nicely. You just have to touch whatever you want to cut. So if you have an anterior lesion, for example, anterior horn of lateral meniscus, you want to reach there. Very difficult to reach from anywhere. And you even take a punch from there, it cannot cut, it cannot go there. So take a RF device, just gently cut it there, slowly, you'll remove. So lately, all my anterior horns of lateral medial meniscus, I use an RF device. It works very well. You have to be a little careful not to damage the cartilage, but I think it is very handy.
Yes, the beauty of the RF device is that you can externally bend it according to your need. That is the beauty of the RF device. You can even bend the RF device tip, suppose to 20-30 degrees, so that you can reach there. Because most of the time you don't have the luxury of having this 45-degree or 90-degree punches, because every punch is 1.5 lakhs.
And they don't work, they get blunt over the time.
The problem is they don't work. And second thing is that they easily break.
Yeah, RF device also having a 90-degree, that's pointed one. So we can use with that.
Yeah, that is there. But the problem is that 90-degree tip is that it cuts very less. It cuts very less, and also this is the cautery part of that 90-degree part is very, very less. It will take much of time.
Yeah, smaller one.
Smaller ones, yeah.
Yes.
Any questions from any other participants? So, sir, we will move on to the complication part of your talk.
Do you think there is a time and tempo? We are already 1.5 hours.
Yeah,
IPS, do we go ahead and some other day?
Okay, sir. Perfect. Absolutely. No issues.
Because it will take another 45 minutes to 1
hour.
Sir,
I'll talk to you and then we'll fix up another day.
We can fix it some other day.
It makes
Okay.
sense. We go
Maybe we
slow.
can have some more questions on this.
I think the complication part should have the another day, because that is a
Yeah,
big,
yes.
Yeah, we will talk another day.
because
Suman
sir,
bhai.
because my side
Dr. Vyas wants to ask something.
Yeah,
Yes.
Sir, many a times it happens that while drilling a tibial tunnel, there is a generation of metal debris. So we should go after them and get them out for thinking that it might lead to synovitis, or we just should let it be.
I wish I could take them out.
You
There's
cannot.
no way. There's no way you can just wash it out. Whatever comes
Wash
out,
it
you
out.
can't chase them.
Sir, a question on a chat box. Sometime our instruments get corroded. So if you can see under the arthroscope, your probe seems have some amount of corrosion. Does it bother you, or you buy a new one, or is it okay that even it is slightly corrosion or some?
It is not okay. Number one, it doesn't look good, and that means your assistant is not taking care of the instruments. But if it is too bad, you change it. But I think more often than not, it is some blood which they're not cleaned, or it is corroded. So there are some anti-corrosion agents you can put. You can clean it. I don't think it bothers me, except that since I give recorded CDs to patients, sometimes I worry that patient might say कि ये कौन से instrument से डॉक्टर साहब surgery कर रहे हैं. So that's what worries me, that the patient can recognize those things very quickly. So,
I think yes, sir. I think this was happening previously when people are using in our old era, like when we started doing 27, 20 years ago. That is your formalin tablets and all these formalin soap gauges. Now people are not at all using this formalin thing. And if you are not using the formalin thing, the corrosion is extremely is unlikely to happen, unless and otherwise you are not absolutely taking some taking care of your instruments.
and some of the,
yes, sir.
I think Indian instruments have more chances of corrosion.
Yeah, so
So
especially
very often I've seen it happens in Indian instrument. Whatever they do, I don't know what metal they use.
But if you refer to the Indian probe, hardly it will take 500 rupees. If you some spot, if you buy another one new, it is only 500 rupees.
Yeah, I agree. So I'm not saying Indian probes are not good in instruments. They're good, but the reason is they get corroded often, which is okay. It doesn't bother you.
Amol has a question. Amol, yeah. Amol.
Sir, about recording, you said which recorder do you use, and is it wise to give the CDs to each patient medico-legally, or it is better when if asked then only we should give?
So there are different kind of recorder. We have a Sony recorder. I don't know what it means, but just everything goes there. It is in the hard disk, and then we can copy it on pen drive, or even we can make a CD, and different available. There are quite a few of them cheap also available. Different people have different recording system. So you can record. So one thing I must say, as an arthroscopist, you should always record your arthroscopy. Not for giving to the patient, but for learning yourself. Always go back to in the evening, open your own recording and see what you were doing, where you were getting stuck. And very often you will get a lot of learning from seeing your own videos. That's number one. So recording is a very good idea, at least initially when you're learning. Now, secondly, it is a very good idea to keep a record for yourself, because tomorrow patient has a problem. You want to see what you have done, why it is happening. At least you can see the recording. The third is whether you should give it to the patient. In my opinion, you should not give it to the patient, because it can always fire back. But I give it to them because I think it is a plus point. In the sense, it makes them feel that I'm very transparent. I have nothing to hide. And till today, now in last 30 years of my experience, nobody has come to me because I gave them CD and they went to IPS Oberoi, and Oberoi had time to see my CD, and he told them that Dr. Maheshwari has buggered it up. It has never happened. It doesn't happen. Because, we are scared that they go to the court, this, that. Once you're doing your job properly, and then why will somebody raise a finger on you? In fact, it helps me. Sometimes I tell them, okay, here's the CD. You go and show it to Dr. Oberoi. Maybe he has something to add. And as you know, Dr. Oberoi, being a gentleman, would never say anything wrong about me. So it actually helps. But I agree.
So pictures can be given instead of videos.
In the beginning, don't do it. Don't try to act smart.
Problem is the medico-legal issue. I think there are few cases are there. Your point is very good. Your medico-legal issue is still there. If you have done something wrong, and if it goes into the court, and if your surgical part was not proper in that CD, you will be in problem. That's why
That's why I said don't give.
I am not naming one of the corporate chain hospital in India, one big corporate hospital. They don't allow any arthroscopic surgeon to record their surgery in any of the chains in the country.
Not even record.
Not even record. Not even, you can record, you can keep that, but it will not even record. It is not allowed. It is not allowed in their chain. Second question is that he was asking that how to go ahead with your recording system. Even if you do with your simple TV monitor, you can record. You have to only invest hardly 2,000 rupees. There is a small apparatus is there that is available in the market. You go there, and if you go that input and output on the TV monitor, and if you connect it to your laptop, everything will be turned into your laptop, and it can be written on the disk. So this is not a very costly affair. Even whenever we
are there, yeah.
It's called a capture card. It's called a capture card.
It's very easy.
Capture card can be downloaded from the TV or from your system also.
Even in Odisha,
another output.
Even in Odisha, when we started doing the arthroscopy long days back, when Ranjit was not still there then, we have used this sort of system. Those are obsolete now, but this is for the just information sake.
Okay.
So I think recording, as far as recording goes, do record.
Just for the sake of information, so even if a video is recorded, as far as medical legal system is concerned, if there is no name on the video, nobody can hold you liable for that. Even if something goes wrong, God forbid, it cannot be done. The moment you write the name of the patient and the date, then we get into trouble. So even if you're recording, it is not wrong that you record. You can keep it for your medical purposes, for presentations. But this is an advice that you don't put the name. Normally, all the softwares that we have, you put in the name of the patient before. So instead of just putting the name of the patient.
Yes, yes. Problem is that when you reach at the status of Dr. J. Maheshwari, you can do what, even if you give blank CD, that will work.
No, I don't think you should give the recording. So you must record and see your recording. Don't give it. I am advising everybody.
I will advise my juniors, don't give it to the this thing, so that if you are really confident and if you are really expert and you know that it is good. It is good, but suppose you do a both-bone forearm plating, you are giving the X-ray. It is no harm. But problem is that arthroscopy is so tricky subject. You can do something this way, that way, and even if you have done a best ACL job, still that ACL can fail. It is 1/3 ACL failure. So you might be in problem. So I think you can do it for your learning, as Sir is telling, but it is not to be circulated through the wide media.
So one of these days, I may have a case against me and I'll stop giving.
Yeah, Vishnu, you have a question. Yeah, we take your question. Vishnu, unmute yourself, please.
Unmute Vishnu.
Unmute Vishnu.
Yes, we all pray that it is not there.
Maheshwari sir, you have 30 years of experience in arthroscopy.
Yeah.
Just I want to ask you, in these 30 years, what is the evolution of your sterilization method of cables and scope? And if you divide in 3 decades, first, second, third decade, and what is the outcome of each decade, sir?
So, and sir, corollary to that, there is a question: what is the advice of the panel for the freelancers when they are doing 2-3 cases at 2 different places to ensure the sterilization? What should they carry and how will they ensure that?
I think Maheshwari sir is the best person to answer this question, because he has seen all the sterilization methods, because we have all started with the formalin tablet, and we have also started with the formalin liquid soaked in gauze.
So in my next presentation, which is complication, I made a slide, problems of a traveling surgeon. So in that, it is one of the point, how do you sterilize? Because a lot of us are traveling, operating here and there. So maybe next time when I talk, but about this point of sterilization, when I started arthroscopy, everything used to be in formalin chambers, including cutters, including probe, including, everything used to be in formalin chamber. And then we went to the next step where I decided that all my metal instrument, I will start autoclaving, the hand cutters and things like that, probe, etc. And all my like sensitive instrument like scope and the light cable will go into camera, still not sterilized, use a cover. But my light cable and my scope will go into Sidex. It used to be overnight Sidex then. So my first case, I used to keep them in the night, and in between the cases, maybe 2 or 3 those days at the most, we'll keep them again, wash them with saline, normal saline, on the table with gloves on, wash them and directly put them into saline there. And in between, half an hour of keeping them in Sidex was kind of acceptable option. That's what colleagues say, this is okay. So in between, Sidex again, and at the end of the day, clean up everything, put them again in formalin chamber. So this used to be the routine. Now with rapid Sidex, and then third phase came when the Sidex became a rapid Sidex, half an hour, they tell me, I don't know what it means. So now you can go in the morning, take it out from your formalin chamber is more or less like your store box. It is keeping it sterilized, so-called sterilized overnight, but I don't depend on that. And I take them out in the morning from formalin chamber, put them into Sidex and sterilize them. And now, of course, we put them in Sidex only. We have no formalin chamber. So all the metal things are sterilized nowadays. All the plastic things undergo ETO, and all these, both these two things like cable and scope, they go into the Sidex, which is a rapid Sidex in the morning. That's what happens now. Next is, of course, they say you can sterilize your scope, you can sterilize your camera. I have not reached that stage yet. Maybe I'm lazy, though it is possible, but I don't trust the people whether they're going to keep the pressure 70 or 1000. You never know. And if your instrument gets spoiled, they can only say sorry. You can do nothing to them. So I'm a little bit scared, and I only do something that's in my control because all these are expensive stuff. That's what I do now.
Yes, the problem is always the sterilization of the instruments, and if you have the luxury of doing these things with the soft instruments like your camera and all these things, the best way is the plasma sterilization.
Yeah.
The problem is the plasma sterilization. The installation is very costly. It starts from 50 lakhs. This is one simple installation. I do have the facility of doing that. So in between the cases, I do that because it takes hardly 45 minutes, 55 minutes, rather to be very precise. It takes 55 minutes to be in and out system. But otherwise, you can use the Series telling the quick, rapid Sidex sort of thing. But problem is that never use whenever you are traveling surgeon, never use whatever they are using for the general surgical people. Because whatever the same, if you use the same tray, Sidex tray, what the general surgical or the urosurgical people are taking, then you will be conflicted and you will be contaminating with the atypical mycobacterium. That is very, very hard to cure. And after 6 weeks of timing, you will see that one of the port and mostly the tibial side is starts creeping. That is the main problem. So whenever you go as a traveling surgeon,
you have your own Sidex.
Yeah. So either you have your own side.
Even don't take the tray. That tray has to be, if you just clean with the spirit and whatever, and try to be, you tell them that I am the arthroscopic surgeon, please don't give this to urosurgery and the general surgery. Otherwise, you will be problem with the atypical mycobacteria.
Okay. Yes, Sandeep has a question. Sandeep.
No, regarding the same thing, sir, I do sterilize everything with autoclave except camera. I use earlier I used to use formalin tablets, later on Sidex. Now no Sidex, no formalin tablets, only autoclave, and except camera head I use camera cover. Rest everything, even shaver blades and all, everything I autoclave it.
This is for the juniors, those who are still wanting to buy the camera. I will request that you try to buy the autoclavable camera.
Yeah, now there are autoclavable cameras as well.
Then this problem with fogging and all these things are not there. It is autoclavable lens and autoclavable camera, both are available in the market. And this is not very costly. If you know that, you will obviously buy the better one. Whenever you buy your best phone, probably you now try to buy the Samsung S9, S10. So why you are not going to buy Samsung S4? It is like that.
Okay,
then Sandeep, then how you sterilize your plastic disposable things?
Yeah, so plastic disposable, I'll tell you.
Disposable is 20 rupees. It's
20 rupees. Shaver blade is stainless steel blade and burr, stainless steel autoclavable. Now,
No. Disposable, if you reuse them.
Plasma.
Then disposable plasma, because if you have the facility of 50 lakhs, then only you can use the plasma.
I was talking about the scope, light source,
the
cable,
sheath
and shaver.
instruments.
And shaver, yeah.
whatever he is talking, everything is now autoclavable. Everything.
Yes.
So you
Okay,
better go with the autoclave. It will be done. But problem is that with this autoclave is not like your metal autoclave. And try to teach your sister. Otherwise, it will come as liquid.
Okay.
So I'll tell you, my comment on this is you learn your own system. For example, I always say, which is the best car? Best car is Mercedes. Now you buy Mercedes in Delhi, you will be actually crying because somebody will take away the mirror and it will cost you 1 lakh. Some rickshaw wala will thoko you on the side, it will cost you 2 lakhs. So, the best is always the best for you. So if your system allows it, for example, in my hospital, we have a plasma, we have everything under this roof, but I don't trust the human beings.
Yes, that is the problem.
Taking things from A to B to C, who is going to drop where? I don't know. So if I am not in full control of my system, I don't use it. So I have to have a full, this is a very delicate instrument. And even with so much care and so much delicacy, still every other day, you have a problem. The scope is fallen, it is broken. So it's a question of organizing your own setup. If you have your own setup, do everything yourself. You have a good staff to take care. Yes, do the best possible. But sometimes you have to compromise because on everyday basis, you cannot keep control on people. That's the problem.
You should have 2 dedicated staffs, one for instrument and one for OT setup.
Probably for the juniors, I will give you one trick that when you buy your own lens, then every time at the end of the surgery, you take care of your lens, you dry it and you put the cap. But when it is a Badwari sort of lens, you do the surgery and keep it on the tray. You never do that. So that Badwari lens never lasts more than 3 months because every time people are washing and putting on the base on your basin and their sisters and the class 4 is washing and it is throwing and after 3 months there are 100% there will be scratch. If you find no scratch after 3 months, I will say you are lucky. But if it is better to have the old lens so that you clean yourself.
Yeah, Vishnu.
Okay, Vishnu, last question and then we close.
The last question. Nowadays we have a flash autoclave in the OT. So is anybody can really help me? How does really it help in the arthroscopic cables and scopes? Does it really sterilize or any opinion on that?
No, flash I think we use only for the instruments which fall down, which is something like a probe or maybe a punch which falls down. Other than that, we don't use flash.
Can you the same thing for the cables?
No, we don't.
The same for cables?
No.
Unmute.
If the recommendation is not there by the company that it is autoclavable, if you give that, it will come as a liquid. So don't give that, even if you flash or non-flash.
Yeah, it's only for 15 minutes.
No. It is flash autoclave is just for the fallen instruments.
Fallen instruments? No, nothing more.
Because even the flash autoclave, your sterility is not 100%. This is just for the saving purpose. Suppose if you are doing a by total heave and your impactor goes off, then you have to go for the flash autoclave. Otherwise, you don't go arthroscopically this way. Rather, you go put in the fresh parasafe sort of thing. It will be more useful and more safe.
Okay, perfect.
Yeah, Dr. Subhranshu, you had a question last. Dr. Subhranshu.
Subhranshu, he's not asking.
Subhranshu is unmuting not. He has to unmute.
Okay. So I think that's perfect. I think Dr. Maheshwari, you were very, very interactive, and I think that is the best thing about this. Tejas, you have a question before we close? No, I think that's okay. So, sir, no more questions. Everybody is just sending thank you messages to you. We would love to hear to your next presentation on complications, and I'll fix up a time with you whenever it is good for you to come up with that presentation. We do have 2 things which are coming up in this week, sir. One is Dr. Bhasin, who is we are launching his recorded video about stiff knee. The question which was asked, and I think he has got a 30 minutes video of how he does an arthroscopic arthrophybrollysis. Also, on the end of this week, on 13th, we have McFarland, Dr. McFarland. He is presenting his experience
on reverse.
He's from John Reverses. He's from John Hopkins School of Medicine, and he has got an extensive experience about reverse shoulder arthroplasty. I think these 2 are interesting to be seen topics this week on IAS YouTube channel. And sir, I will be in touch with you to fix up a date
Sure.
when it is convenient to you regarding complications.
Good.
And I think your idea of this interaction and getting people on board is an excellent thing, sir. We'll continue with this.
And I
Thank
think
you
in
very much.
complication, I would definitely, and let me tell already, at the end of it, I like each one of us to share at least one complication which they remember they did and why it happened and how they have changed
Right,
after
sir.
that. We all have
Remember
gone
a lot, sir.
It will be very good to share those complications.
So guys, if anybody of you are tuning in for the Dr. Maheshwari's next time,
Be
please
prepared.
bring your complication. Be prepared. The webinar is other way side this time. Thank
Yeah.
you very much, sir, and have a nice day.
Bye-bye.
It is always an
Thank you,
honor to
Sandeep,
master
for
this.
organizing. Thank you, Ranjit, and thank you, Aslam, for coordinating everything. And thank you, friends, for coming on board. And
Thank you very much, sir. It was a
questions.
pleasure.
Thank you.
Take care.